the immunotherapy being available um, for patients in stage 4. What has been your experience of cancer patients, getting choice for immunotherapy versus chemotherapy? I mean, I guess any patient are presented with several options. So, what is coming from a patient perspective? How do you navigate the various options available for them? What is the best way of gauging that? Um, and then, what are the differences? In like early stage versus advanced stage in terms of immunotherapy? Is that an option um, for early stages of cancer? So the two questions.
So are you sure you have another hour? This question, this question is a loaded question. And if you want to answer this question appropriately, you need another hour or two for explanation. But
another, with probably an example, and Samya has of course put out the next session coming up where we can discuss more. But with examples from your own patients, or anonymously, you could talk about gauging the different options always available, right? And that's why I think patients take on multiple recommendations and look at multiple doctors to see that they're getting the best course. But now that that immunotherapy is out there, it's real, it's been tested, research is out there. But you also have this equally effective mode of chemotherapy and radiation. How difficult or easy is it for patients to select their treatment option?
I would let Dr. Singhal answer, since you were presenting on, and I can add on later on if needed. Yeah.
Okay, thank you. To answer your question, I would divide into two groups. One is early stage and late stage cancers. Now, early stage or late stage division is one, then also the type of cancer we are talking about, right? I have to say that for early stage cancers, immunotherapy in general, it is hard to say whether you should take it or not. Every cancer is different. Their treatments are different. And the most of the treatments, we oncologists go by evidence-based. What is the guidelines for that specific cancer? So patients can definitely ask, what about immunotherapy when they go to their physician? They should be aware of that option as an available option. But at the same time, it is, I have to say, it's a landscape changing for more stage 4 than early stage. But most, again, each cancer is different. So generalizing and talking as a platform for cancer would be wrong at this platform for me to say anything. But patients should feel that if they have stage 4 cancer, that is not the end of their life. Actually, now they should feel empowered, I would say, that they have options and they may live long. And Dr. Agarwal would agree with me. I would say that the immunotherapy has changed more landscape of the stage 4 cancers. Having said that, sometimes we use, it's a case-by-case basis, even for early stage. I have a 90-year-old elderly gentleman. He is bladder cancer, and he cannot tolerate chemo. He has PD-L1 positive disease. Would I use immunotherapy? Yes. But if this gentleman was 60 years old, and if he had early stage bladder cancer, the treatment decision would be based on his cancer, the type, a lot of different case scenario would come into the play. So I think that would be another discussion. As Dr. Agarwal just said, it will take us a whole session to talk about cancer, and we might have to go cancer by cancer to basically highlight their treatment options. But having said that, this is definitely, and the second most important, which I would end, what I'm saying is a personalized medicine or targeted therapy. you definitely should bring out that discussion with your oncologist if you have stage 4 cancer, because the treatment scenario, treatment decisions, a lot depend now on your specific gene mutation, your specific armatorium, what else I can do to prolong life. And many, many, many people are living longer. Another thing I would add, I did not bring, my goal was to present how immunotherapy works, is maintenance therapy. That is another changing field of our cancer management. Is we now put a lot of patients, and immunotherapy is a part of maintenance therapy in many cancers like lung cancer, like bladder cancers, many cancers. So that is another thing to add. But with that, I'll let Dr. Agarwal add to that what she thinks in her practice.
I would agree with that, but I would take actually some, opportunity to answer some of the questions. And there are a few on question and answer. So Mohan Attawar asked, what tests are used today to qualify for therapies? So, so the tests generally are used based upon the origin of the cancer. So for example, in breast cancer, we still are using hormone receptors and HER2/neu, but there are tests that we use which are agnostic of the cancer origin. So we use next-gen sequencing testing, and like Dr. Singhal said before, PD-L1 expression on the tumor. So PD-L1 expression on the tumor is correlated with response to immunotherapy, and that's one area where we can use that PD-L1 expression to determine who is likely to respond to immunotherapy in stage 4 diseases. Besides that, when we do next-gen sequencing test on the tumor, it actually tell us which are the targets that may be overexpressed, underexpressed, or targetable, and that gives us some more therapy options, which include immunotherapy and maybe other targeted therapies that may specifically target that altered molecule on that particular cancer. And one of the alterations that we look at, as she mentioned before, is MSI, microsatellite instability. Patients who have MSI high tumor respond to immunotherapy. The other one, we look at number of mutations in the tumor. So if there is a tumor which has a lot of multiple mutations, those are considered immunologically hot tumors, and they may respond to immunotherapy a lot better than some of the not. And some of these things are organ specific. So for example, lung cancer specifically is generally considered an immunologically hot tumor. Squamous cell carcinoma that come from the head and neck and the cervix are considered immunologically hot tumor, and they may respond to immunotherapy a lot better than other therapies. There are trials which are looking at a role of immunotherapy early on in early type of cancers, such as bladder cancer, and we are waiting for more data. But because some of the side effects of immunotherapy could be unpredictable and lifelong, one has to be really careful using just immunotherapy just in everybody in early stages who are likely to live for a long time. So I think many of our treatment options are based on the guidelines and the previous experiences that we have. Then there is a question from Srinivas Ramachandra. Can you talk about any cancer specific to South Asian community where immunotherapy has made a big difference? There are no, these are not the cancers specific to South Asian community. These are the cancers that are actually found in general population, which are also true for South Asian community, I would say. So cervical cancer, lung cancer, head and neck cancer, all of these cancer actually respond to immunotherapy in all the communities alike, whether this is South Asian, Asian, or Caucasian, or even an African American population. So here I would not say that there is anything specific to South Asian community. Do you agree with me, Dr. Singhal?
Yeah, and actually, in South Asian community, two cancers come to my mind. One is hepatitis B related hepatocellular carcinoma. And the second cancer that comes to my mind is head and neck cancer, which is actually a very common cancer in Indian population because of chewing tobacco. Squamous cell cancer, as Dr. Agarwal just pointed out, is immunohot tumor. Immunotherapy definitely is a great option. and PD-L1 looking at early time is a good to know. The other treatment, actually, I would like to point out hepatocellular carcinoma. Earlier, just up to about 6 months ago, we were using a drug called Nexavar or sorafenib or lenvatinib as a first-line therapy. You would be surprised now that in the last 6 months, the first-line treatment has changed and can be. It's still ongoing studies, okay? But this is a phase 3 trial that passed using immunotherapy plus Avastin is now considered. Avastin is a anti-angiogenesis inhibitor, a targeted therapy against the VEGF receptors of the cancer cells. And that is one of the cancers which is very commonly seen in the Asian community who have Hep B, actually positive disease. So, but there's a lot of nuances to this, but I just wanted to point out hepatocellular cancer is another very big cancer where it's a landscape changing, where we used to use, sorafenib or lenvatinib as a first line, and now even this got first line approval. So immunotherapy is getting approved first line in many cancers. The South Asian population has the only thing I feel the immunotherapy is a very costly agent. It's not, the studies in South Asian population is not like a race based or the Asian population based. It is general based. It is not easily available. If we are talking, if many of our audience today is Indian, it is not as easily available. It's a pretty costly drug. I don't know if you know the cost, but to my knowledge, the monthly cost of these agents is $4,000 per month, just to put it out there, So I don't think it is as easily available. It's as easily used in India as far as I am aware of, but it is coming in a big way, I think, globally. Just to, put it out there. But yeah, it is definitely. And I actually want to share one as I end this where I'm speaking, is I have a 94-year-old grandma, and she was referred to me, and she was having severe abdominal pain. She had a big mass in her stomach. She had a stomach cancer. So our palliative team came and said, why don't we make her hospice? So, and she was bleeding. Her hemoglobin was low at 8. As I said, we Asian population really like to go full force for our parents, our loved ones. And so came the family and said, is there anything, Dr. Singhal, you could do for my mom? I said, see, first thing you should do is radiation. Let's stop the bleeding. So we did the radiation. And then I did what exactly we should do is something called what Dr. Agarwal pointed out, next-gen sequencing. We looked at the MSI receptor and she was MSI high. You wouldn't believe, but this is true. My 94-year-old patient is 2 years out and her cancer is nowhere seen. We didn't use chemotherapy, but I have to say the immunotherapy is what gave her the life back, which I would have said she would have not lived 2 more years. And she lives a great 94-year-old healthy. Asian genes are strong. Some of the patients live long and she's back to living like a normal mom. This is a really great agent and is being used in every single cancer I can think of, is being researched and seen how we can use them. With that, I would pass on to Dr. Agarwal.
Yeah. Is the small cancer of bladder is treated the same way as small cancer of the lung? And what is the response rate to immunotherapy? Yes, a small cell cancer of the bladder is treated the same way as the lung, and it would respond to the same type of chemotherapy, which is cisplatin and etoposide. But these days, immunotherapy is approved for small cell cancer of lung or any kind. And I would definitely include immunotherapy. There are a combination of immunotherapy plus chemotherapy that can be used. And if the patient is not able to tolerate chemotherapy, immunotherapy alone is effective. Actually, I have a patient who, again, like Dr. Singhal, she's 84-year-old, was with neuroendocrine tumor, which is a type of the small cell cancer, aggressive small cell cancer. And she is doing amazingly well with immunotherapy alone 1 year out. So again, I mean, we all have examples and anecdotes of the patients who are doing extremely well with immunotherapy. For small cell cancer, small cell is considered immunologically hot tumor, and I would definitely use immunotherapy either alone or in combination, depending on the patient's general health and condition. And then I think there is another question. let's see, that was in the chat. What is the difference between immunotherapy and targeted therapies, and how these emerging treatments relate to people who are on anticoagulant like Coumadin and might need ibrutinib? So I think I would differentiate immunotherapy and targeted therapy in two ways. Immunotherapy is making your own immune system fight the cancer. It's not specific. It is not specific to the tumor or to the type of the tumor. It is basically killing all the tumor cells if it can recognize. The targeted therapy is slightly different. It is basically taking into account of any mutation on the cancer cells. So if there is a mutation or there is an alteration on the cancer surface cell, every cell has basically divides and grows based on some of the markers on the cells or some of the cytokines or hormones inside the cells. And if we can identify one particular alteration and can develop a drug that can attack or inhibit or exaggerate that mutation, that is called targeted therapy. So ibrutinib is a targeted therapy. It is basically attacking a specific agent called Burton kinase, and it is a Burton kinase inhibitor, which is found on certain B cell malignancy like CLL, like some other B cell lymphomas. It cannot be used to treat a lung cancer, right? There is a targeted therapy in lung cancer, which is one example is Tagrisso or osimertinib, which is used if that particular cancer has another mutation in the other gene is called EGFR mutation. So the targeted therapy is specific for a specific mutation. It may or may not be tumor specific, but it cannot be applied generally. Whereas immunotherapy can be applied a little bit more broadly. That would be my answer. Ibrutinib, again, specific to ibrutinib, it causes bleeding tendency. So one has to be really, really careful if somebody is on Coumadin using ibrutinib. And I would look if there is another option available who is on Coumadin. I mean, there are other targeted therapies such as venetoclax, which inhibits another marker in that particular patient, because both ibrutinib and venetoclax are kind of effective in similar tumors. So I think that, and if you want to talk to me offline, we can talk about that. But this is the difference between targeted therapy and immunotherapy from my perspective.